Hi, my name is Ann Kitchens, and I am doing this video for my gestational diabetic patients who we can't physically see in clinic right now due to circumstances surrounding the coronavirus. We want to keep everybody safe and keep you at home if possible. So we're doing this video just to ensure that we give people the best care possible during this difficult time. But gestational diabetes is something that we can manage remotely. So we'll do this through a combination of this video, our telephone call that we're going to do with you for an initial visit, and then also subsequent communications over my chart, telephone if necessary, anything we need to do to keep you guys safe, we are definitely ready to do. I wanted to also do this video to make sure that we have a consistent educational experience with our gestational diabetics. So I'm going to give you an overview of gestational diabetes now that you can watch with your partner or any family or anybody who you'd be wanting to watch this with and might have questions for me, so that when we talk on the phone, which is really just more of a one-on-one format, you can bring those questions to me and you have a little bit of time to think about things before our phone call. So gestational diabetes is very common. I see probably up to about 10 new patients a week with gestational diabetes. So it's not, I don't want you to think it's uncommon, and I don't want you to think that it has anything to do with anything that you have done or any choices that you have made in pregnancy. We know that gestational diabetes is a combination of genetics mixed with the placenta. So by genetics, I don't necessarily mean if anyone in your family is diabetic, although a lot of times that is the case. I mean more that when you were formed as an embryo, everyone has certain genetic blips that occur whenever the egg and sperm combine to form them that put you at risk for certain things throughout your life. And gestational diabetes is a not uncommon genetic blip that you can have. The placenta is also a very, very big stress test for your body. So the placenta asks a lot of your pancreas when you're pregnant. And so as time goes by and the placenta continues to develop in pregnancy, gestational diabetes tends to get worse. I always tell my patients it's not a bad thing that you've been diagnosed with gestational diabetes, because we'd rather know that you have it and intervene if we need to, versus not intervening and not realizing that you have gestational diabetes and ending up with complications after you deliver. Those complications can include a large baby called macrosomia, which can make delivery difficult. Also includes the baby could potentially have hypoglycemia, which is low blood sugar. So when you're pregnant, the baby is sort of floating around in this swimming pool of glucose provided by you. And when the baby is delivered, their pancreas has been secreting insulin in response to your glucose level. So when the baby is delivered and the baby's on its own and doesn't have a continuous glucose source or that swimming pool of glucose that it's floating around in, it can subsequently have hypoglycemia due to excess insulin production by its pancreas. So that's a complication that can be fixed with supplying external glucose to the baby at delivery. But that can be problematic because the baby sometimes has to spend time in the neonatal intensive care unit and can delay their departure home with you. And the final complication that I always touch on, but I want patients to not get too upset about this, especially if you see this on Google or some other research that you've been doing, is there is an elevated risk of stillbirth with gestational diabetes. However, the risk for that does not become markedly elevated until your glucose reaches a certain level, which is around 200 or 220 consistently. So we will do everything in our ability to get the glucose down that we can possibly do. And that is, that outcome is easily preventable with intervention. So I don't want anyone to worry about that outcome. So those are the reasons why we take gestational diabetes very, very seriously, and we want to get glucoses looked at and under control if they're not where we want them. There's a couple ways that we're actually going to monitor your glucose. So one, the most important way is for you to check your glucose at home. So we will be issuing a glucose meter for you at your pharmacy. My medical assistant will verify your pharmacy and we'll send that out for you. I will also be sending you, after our initial phone call, a link to several websites that will show you videos on how to use the glucose meter. And the meters also have instruction books that come with them that are extensive and will tell you everything you need to know about the meter. So what we want patients to do is check your glucose 4 times a day at home. We've picked 4 different time points that if your glucose is okay at those different time points, then we know that you're okay the rest of the day. So those time points are fasting when you first get up in the morning. We want that glucose to be under 95. Fasting doesn't have to be the same time every day. It just has to be whenever you get up and before you've ingested any calories for the day. We also want to test your glucose either 1 or 2 hours after you eat. Ideally, I like to see a 1-hour glucose check because that tends to be the worst number. So again, we don't want to hide from high glucose numbers. We want to uncover them if they're there and get them treated. The 1-hour post-meal glucose should be under 140, and the 2-hour post-meal glucose should be under 120. So again, you don't need to check both. You just need to check one or the other. My preference would be a 1-hour post-meal glucose check. If you miss the 1 hour, that's fine. Just do a 2-hour post-meal check. And then what I want you to do, and again, we'll go over this on our phone call, is I want you to write down those glucose numbers. And then once a week, preferably on Sunday or Monday or whatever day is easiest for you, I want you to take a picture of those glucose numbers and submit them to me on my chart for my review. And we'll be doing that every single week. If you have glucose numbers that are 10 points or more above goal at any given time frame, I would want you to email me or message me on my chart sooner so that we can get those taken care of as soon as possible. Because again, gestational diabetes tends to get worse. It almost universally gets worse as the pregnancy progresses. So if you're 30 weeks gestation and your fasting glucose is 105 and we want it to be under 95, it's going to be very difficult to get that at goal and make changes. So if we find that your numbers are above where we want them to be, it's easiest to intervene early with medication that'll get those numbers down. So that leads me to my next point. If your glucose is above where we want it to be, again, at any given time point, we actually, the most tested intervention is insulin. So that is going to be our first recommendation. There are a couple of medications that we can use in gestational diabetes. However, their glucose control tends to be a little less predictable and a little less successful than insulin, which is something that we can use to get our glucose numbers precisely where we want it. And it is safe in pregnancy. The big risk with insulin is hypoglycemia or low blood sugar, which in pregnancy is a glucose under 65. And the way that we do insulin is that we start with a small dose and we titrate up very slowly day by day so that we can avoid hypoglycemia. And we'll talk to you about that more when, if that comes to that for your particular case. But that is the safest treatment and the one that we typically do recommend for people. Having said that, the majority of patients, the glucose that is the most problematic is actually the fasting number because that's the one that you can't really do anything about. So the post-meal number you actually can modify to some extent with your diet. So if you find that when you start checking your post-meal numbers, you're going routinely above our goal of 140, that would be a time to change up a little bit what you're eating, go from more simple carbs to complex carbs that don't spike your glucose as much. Cut out a little bit of carbs, cut out some sugar, and we can usually get that post-meal number under control. But the fasting number is more difficult because you've been asleep all night, so there's not much to be done for that number. The reason that the fasting number becomes elevated is that your body needs glucose 24 hours a day for you to stay alive. And the reason that we don't all die overnight when we're asleep is because your liver actually stores glucose and feeds you little snacks all night long while you're asleep. And so a lot of times, and especially during pregnancy, those snacks are actually worse than what you would eat during the day when you're awake. So if our pregnant patients could stay awake all night and eat snacks every few hours, your fasting number would probably be just fine, but we're not able to do that and we don't want you to do that. So the fasting number is the one that tends to become elevated first, and that's something that is difficult to do much about. It can sometimes work for people to eat a snack before they go to bed at night, something with some proteins and a little bit of carbs. the shorter you make your fast overnight, the better your glucose will be. So that's why we kind of recommend that bedtime snack, but that is not a cure-all, and it only helps your glucose maybe at the most about 5 to 10 points, and that's it. So again, the most important point that we want to make is if particularly your fasting glucose is above goal, if it's above goal more than 4 of the 7 days of the week, you are going to hear a recommendation from us to go ahead and start insulin, which we will walk you through that, again, providing videos, and we also have nursing staff that can walk you through it via the telephone too, to help you guide you along the way to doing the insulin shots. So again, the purpose of this video was just to give you an introductory talk about gestational diabetes that you're able to watch at home. Hopefully ease your mind a little bit going into our first appointment with you, introduce myself so that you guys have an idea of who's going to be watching your glucose and hounding you for those every week. And then we will just talk to you on our phone call, and then you can let me know whatever questions you have. Thanks so much.